Hi, everyone. It's been a really long day, and the good thing about going towards the afternoon is a lot of what I was planning to say has been said by other folks. So that's always super nice. I'm Yen-Chi Lee, Executive Director of Innovation and Quality for the Practice Plan, but also Director of the Center for Population Health Management and Quality. We've heard the other speakers talk about federal level, state level, local level. I'm going to really bring this down to managing the population, the health of one population, which would be UT physicians' patients. To give you some framework, in case you don't know, we see about 1 million unique patients every year, 2 million visits, 2,000 clinicians spread over 100 locations. And so that's a lot. That's a pretty big system to be improving and monitoring the quality of. These are our 6 priority areas that we really focus on. And at the heart of our priority is, of course, our patients. I want to take a moment to recognize, because I think, Serena, you did a great job of talking about the things and the stuff. And I'm going to pull in one of my mentors and heroes. I hear a lot of words being used: team science, learning health system, implementation. But when I look across this room, to quote Fred Rogers, I see a room full of helpers. And because we're living in this chaotic environment, I'm so glad to hear about all the work of the helpers. And I'm going to ask the helpers and HTI in the center to stand up, because these are the people that are doing the work to help our patients. There were more, but then they had to go back to their day jobs. Okay, so of those 6 areas, I'm going to talk about 4 areas. We've heard about this. We really want to optimize patient outcomes, make sure that healthcare delivery is efficient, and make sure that that cost of healthcare is effective, and if there may be savings. So what does that look like at UT Physicians? Well, we focus on excellence, quality, value-based care. We heard Dr. Borwinkle talk earlier about primary care, chronic conditions, and how do we do this work? Well, a lot of this happens in the primary care setting, which I will be giving specific examples during my 6-minute warp speed talk. Thank you, Amanda. Okay, so value-based care. So what does this look like? As I mentioned, we have 1 million patients that we see every year. So in the last year, UT physicians screened, and this is just a swath of our non-medical drivers of health. So here, 165,000 patients for food insecurity from 0 to 100 plus, 74,000 for financial strain, 127,000 for housing instability, 215,000 for depression, which we heard is a huge need in Harris County in Texas. Social connections, 95,000 patients 18 and up screened. And then, of course, physical activity, 61,000 patients. Why I'm sharing these numbers is screening is possible at a system level, and there's a lot of work to do, because keep these denominators in your mind. So the bad news, or a growth opportunity, as we're helpers, is 1 in 10 patients that we screen are positive for 1 or more NMDOH domain. And so here, with those denominators that I shared, 9%, 22%, 61%, 32%. Again, we have 1 million patients, so we have a pretty good swath of Houstonians and the greater areas. So what can we do? How are we screening? Because screening without addressing is just not good science. I think Shrila mentioned earlier the social drivers of health. This is EPIC. I'm an EHR data girl, so I'm going to talk about this. This shows kind of the social drivers of health available within EPIC. And then how do we address it? In addition to the helpers that stood up, we have built out community resources, 3,000 community resources. So when that provider has that 7 minutes in that room with the 15-minute visit patient, they can click this button for any positive domain, and we geolocate the community resource closest to that patient. And we give them a list. It can be on their after visit summary. We know that not every patient can do this on their own. So we have community health workers, CDEs, trusses, those non-physician providers to extend that care. So we heard a little bit earlier about closed loop referrals. Well, within Epic, you can view recommendations and see what resources did we assign the patient. Have we followed up? And using community resource usage, we can follow up and we have community health workers. Did you call the Houston Food Bank? How was that? Can I help you? Okay, so in addition to social, because I only have 3 minutes left, digital preventive care nudges. We've talked about that. On average, it takes 10 to 15 minutes to call a patient and remind them of that appointment or that cervical cancer screening. So we do digital nudges to hundreds of thousands of patients, and here's our success rates. What does this look like? Because I postdoced in public health, we sneak in public health wherever we can. We personalize, we use humor. The flu and COVID-19 are nothing to sneeze about. Get your shot and provide a recommendation. Data interoperability has been spoken about. We have to make data usable to the people that are doing the work. How do we do that? Making sure that the data speaks to them, visualizations, and really catering and meeting people, whether they're providers or community health workers or the C-suite, where they're at. So here's an example of process and outcome measures where we track 45 different quality measures over time, and we get that service area and it drops down to the department or provider level. So you always know how you're doing. And in addition to that, because that's good for monitoring, we need to be able to intervene at the point of care. So we create custom lists that shows every open care gap in that next appointment. We've heard a lot about collaboration. I'm looking forward to working with more of those folks in the room. We heard from Sarat about development and Carlton about CPRIT. So although we are working on caring for our patients, we do understand the need to have a diversified funding portfolio. So this is where we've been. We can do a better job of kind of sharing this work. So here are a few of our publications. And I've talked quantitatively, but not everybody can be spurred into action with a digital nudge, right? And so sometimes you have to extend care beyond the exam room with medical legal partnerships, prescription, healthy eating, physical activity. And then here's one of our programs that we wanted to highlight, which is home visits for postpartum depression. And we just got refunded for this from the Episcopal Health Foundation. So here's our team. We always have spots for more people. So if you're interested in joining us and becoming a helper, if you're already not, doing all your other duties as assigned, we would love to have you. Thank you.